Dr. Lambertini, thank you so much for joining me today in this snippet. It's a pleasure to have you here. And I would like to start this by asking you to give us a quick summary of what you presented today.
Yeah, thank you very much for the opportunity to be here. Today at the San Antonio Breast Cancer Symposium, we presented the results of a large international core study that included young BRCA carriers with prior history of breast cancer. And we wanted to look specifically into the role of risk-reducing surgeries for this special cohort of patients. So we have looked into risk-reducing mastectomy and risk-reducing salpingo-oophorectomy and their association with survival outcomes.
Very nice. I think all of us were very impressed with the data that we saw. And I'm going to ask you probably the question that most of us are asking ourselves when we go back to clinic. So what should we tell our patients on Monday? Should we go ahead and recommend to have one or the other procedure, or should we tell them to go for the two procedures? What are your thoughts?
I think it's important to stress that the patient population included in this trial is a special one because these were women diagnosed with invasive breast cancer at a very young age, 40 years or less, and they were all BRCA carriers. So we are not discussing healthy BRCA carriers, nor BRCA carriers that had a diagnosis of breast cancer at an older age. So these are patients that, being very young, are already at higher risk of developing second primary breast cancer, and they are also BRCA mutated. In this case, we have seen a very important survival advantage in overall survival, disease-free survival, breast cancer-free interval for both risk-reducing mastectomy as well as risk-reducing salpingo-oophorectomy. So the way I would use this data in my practice is for the risk-reducing salpingo-oophorectomy, we have clear guidelines, age 35 to 40 years for BRCA1 carriers, 40 to 45 years for BRCA2 carriers.
Yeah.
And in this case, I will really stick to the guidelines, and I think this data will reinforce the importance of undergoing this surgical procedure at a young age. And the median age of the patient in our study that underwent this procedure was 39 years, so in line with the guidelines. For the risk-reducing mastectomy, I think it's a bit more complicated, the counseling, but I think that based on this data, in a patient that had her first breast cancer at a young age, she's BRCA carriers, I will be more pushing the counseling on the indication to undergo risk-reducing mastectomy, even though the data in the healthy BRCA population are less clear than the risk-reducing salpingo-oophorectomy.
Agreed. Now, maybe switching a little bit of gears, and this is something that I always question myself. BRCA1 and BRCA2 are highly penetrant, well-studied mutations that we know increase the risk of our patients of suffering, a new primary after they've been diagnosed with cancer. Do you think there's any role, or maybe your group has considered this, of looking into other mutations that perhaps increase the risk of breast cancer, not as high as BRCA1 or BRCA2, but maybe they cause a moderate increase in the risk of cancer?
Yeah, this is a very, very important question, and I would say unmet medical needs, because we know that these genes have an alteration in this gene may increase the risk of breast cancer at a different extent according to the penetrance of these genes. However, we don't have a lot of clinical data to counsel patients.
Correct.
For example, on risk-reducing surgeries or treatment outcomes. So I think that we need to collect this data. We are actually planning to run a similar study in the same center. We now have this large network from 109 centers worldwide. And so we are planning to collect similar data, so breast cancer diagnosed in young patients, but in those with germline pathogenic or likely pathogenic variants in genes other than BRCA. It's going to take some time to have the results of this new study, but hopefully we will provide that.
Yeah, and definitely I will say that with the availability of us to test more patients nowadays than we used to have, definitely we're going to find more pathogenic variants in different genes that are not BRCA precisely. I was curious about something. Were you surprised by the fact that patients that had the risk-reducing salpingo-oophorectomy, when we look at the triple-negative group, those were the ones that seems to be favored the most? Were you surprised about that?
Indeed, we have seen an interaction between risk-reducing salpingo-oophorectomy and tumor subtype as well as a specific BRCA gene. So the explanation we have more than for the tumor subtype, I think is more related to the type of BRCA mutated gene. Because BRCA1 carrier appear to have a greater benefit from risk-reducing salpingo-oophorectomy than BRCA2 carriers. And we know that the risk of ovarian cancer in BRCA2 carriers is lower as compared to BRCA1 carriers. The patient included in our study were very young, and the follow-up, despite being more than 8 years, is still relatively low for seeing cases of ovarian cancer. And so we explained that we have explanation for seeing a larger benefit in BRCA1 carrier than BRCA2. For the tumor subtype, to me the explanation is probably more related to the gene, because BRCA2 carriers have a higher risk of developing hormone receptor positive disease. Actually, most of them have a luminal-like disease, while BRCA1 carriers, they develop mostly triple negative disease. So seeing that the benefit of risk-reduced salpingo-forectomy is greater in triple negative than hormone receptor positive disease, to me is probably more related to the BRCA gene than the biology of the tumor.
Understood. Well, Dr. Lambertini, thank you so much for doing this snippet with me today, and I hope everybody continues to enjoy the conference. Thank you very much.
Thank you. Ciao.